in the beginning, it's a scary thing to face, and it's a scary thing to be confronted with. And one of the challenges that I faced is it's a difficult process to understand and take all the information in yourself. But then there's also a process of so many loved ones that have questions that they want answered. I mean, I definitely started this process with a seizure, and I had no symptoms leading up to any of this. So when I had a seizure, they told me that the cause was a tumor. You know, you basically go down this road of, to treat the tumor, you go to surgery, and then you face a diagnosis. And the instant reaction, I think, is to learn as much as you can about that diagnosis through any means possible. And the internet is a slippery slope a little bit. You can get a lot of good information, but you can also get a lot of really confusing information. And so I think I learned to start making lists for the doctors and specific doctors, like these are the questions for the surgeon, or these are the questions for the neuro-oncologist. Maybe categorizing those questions for me and doing my own research and allowing to get that information from the doctors as opposed to coming to too many assumptions online, I found helpful. And the doctors here did a really good job of walking me through those different portions of the entire treatment.
So a glioma is a tumor of the glial cells. The glial cells are sort of supportive cells of the brain. They're not the nerve cells. They nurture nerve cells. A glial tumor is an overgrowth of those glial cells, and there are different types of glial cells. There are astrocytes, there are oligodendroglioma, or oligodendroglial cells, and there are ependymal cells. So a glioma can encompass any of those three types of cells. Gliomas can present in many different ways. They can be totally without symptoms. And a lot of it depends on where they're located in the brain. If it is sizable enough, it can present with headaches, sometimes nausea or vomiting. Sometimes a glioma presents with the patient having an epileptic seizure as their first presentation. If the glial cell or glial tumor is located in an area of the brain that controls motor function, it may present with weakness. If it presents in a sensory area of the brain, it may present with sensory disturbance, either funny sensations, numbness or tingling, or burning sensations. We believe that the risk factors may relate to prior radiation that the patient may have had for some other reason. Probably the only real risk factor we know of, there are certain genetic conditions which can predispose a patient to have risk factors. So patients who have family histories of certain genetic disorders may be more at risk to develop glial tumors.
A treatment plan really is something that is thought of in a very meticulous fashion. That typically means we, as the neuro-oncology team, will address the chemotherapy piece, and the radiation oncologist will address whether radiation is appropriate, and the neurosurgery team would address the neurosurgical options.
Here at Stanford, we really believe that treating the brain tumor patient is a team effort. We're here to optimize not only your treatment, your survival, but also your quality of life. We want to make sure that you can live life as long as possible and in as optimal a shape as you can be. If an open surgery is to be performed on a patient for a glioma, depending on the location, we may or may not want to have functional MRI scans performed or tractography. During the surgery, we'll be doing neuromonitoring to minimize the types of neurologic problems the patient may have after the surgical procedure. We're oftentimes using this stereotactic guidance, which is the GPS of the brain, where we've taken the information from the scan and we're able to see exactly where we are. If a tumor is located in a very highly functional area, we'll sometimes do an awake craniotomy. And in this situation, the patient is given intravenous or by vein sedation to make them a little sleepy. Once we're approaching the brain tumor, we'll lighten the intravenous sedation so that the patient can interact with us. They can talk to us and we can test them to know exactly what function may or may not be where we're located. If the patient's having a surgery where they don't need this, then they're put to sleep.
So after a surgical specimen has been obtained, whether that be a biopsy alone versus a complete or partial resection, we allow for the wound, the surgical wound, to heal before then offering a patient chemotherapy and radiation. Chemotherapy can be in the form of an oral-based chemotherapy called temozolomide, and that is used at the same time as radiation. The timing of the length of treatment is dependent on each individual patient. And then we also have clinical trial options that might be layered on top of standard therapy or may take the place of some aspect of that standard therapy.
So radiation therapy is a way of using electromagnetic radiation, usually X-rays and sometimes other forms of radiation like protons, in order to kill tumor cells. So radiation therapy for brain tumors and brain lesions usually involves what we call external beam radiation therapy or stereotactic radiation treatments. Stereotactic radiation or stereotactic radiosurgery is typically delivered in 1 to 5 sessions. And patients who have smaller tumors typically can be amenable to this type of radiation treatment.
Since we are an academic institution, we really want to offer our patients thorough platform of clinical trial options so that they can consider this as a form of therapy should they choose to want to be a part of the trial. The benefits of a trial are that these are often the newest forms of therapy and kind of the cutting edge new advances within the neuro-oncology world, and we want to be able to offer that to our patients. Every clinical trial will have a list of eligibility criteria, so we do try to pre-screen our patients before they even come through the door to understand whether they might be eligible for a trial and therefore offer those trial options when appropriate. But there are certain cases where the trial might not be something that they qualify for, and we would then be able to offer standard forms of chemotherapy. Because brain tumor patients might be affected neurologically, we do work very closely with our colleagues within the therapy space and rehabilitation space. Those would include occupational therapy that really targets tasks that are really important to their everyday living. Physical therapy might be more important when somebody is affected with regard to their balance or gait or walking. Speech therapy when language is affected, both in expression of language as well as the comprehension of language. And those therapeutic modalities are very much a part of what we do, especially in the post-operative setting. The world of neuro-oncology is evolving at a very rapid pace, and we're very fortunate to be at a time when we can offer our patients both standard therapies as well as new novel techniques for imaging as well as therapeutics and treatment.
I think the most important thing through this process that I've learned so far is that it really is peeling back an onion. So understanding that you initially have to deal with the symptoms that maybe caused the discovery of a tumor, and then there's the removal of the tumor, and then there is a diagnosis of a disease that, kind of caused that. And as you peel that back, learning how to ask the right questions and have faith in your medical team and research and understand that it's gonna play out over time